prevalence इतनी नहीं है, तो we will come to that inshallah in this slide as well. सही. So this to me is a challenge because here we have all the professors sitting here and the spectrum goes from here down to all the medical students. So कोशिश होगी कि कुछ ना कुछ इसके साथ इंसाफ किया जा सके. आइडेंटिटीज़ की बात है, सारी बात AIs पे चल रही है, तो कुछ अनआइडेंटिफाइड आइडेंटिटीज़ अपने बारे में शेयर करना चाहूँगा. ये जो AI की बात आज डॉक्टर सना ने कर रही हैं, I did this in 2002. I did a Bachelor of Computer Science in this. So this was the project at that time was this holographic imaging की. फिर I joined Zabist and वहाँ पे हमारा जो फाइनल ईयर के साथ I had a clash so couldn't continue. So the idea, alhamdulillah, we are there. This is now a reality. At that time it was just हम लोगों की level पे और पाकिस्तान की level पे all of this seemed like a dream. So alhamdulillah, now things are going on and inshallah we'll be trying to adopt these things and make the way forward. एक और छोटा सा तारुफ कि I'm also a student of Dars Nizami at Hidayah Academy and I'm doing it in Darj Arabia. इसमें important बात ये थी कि अगर हम बहुत सारी principles ऐसे हैं जिस पे अगर हम अपने इस्लामिक प्रिंसिपल्स को फॉलो करें तो शायद हमें एडवांस इतनी सारी चीज़ों की ज़रूरत ना पड़े. तो ये बहुत सारी चीज़ें हैं शायद जिनमें हमें एडवांस के साथ साथ हमें कुछ ना कुछ अपनी बेसिक्स अगर हम सही करें तो प्रॉब्ली चीज़ें और मज़ीद बेहतर हो जाएं. सो विद दिस वी स्टार्ट अवर टुडेज टॉक एंड सो डिस्क्लोजर्स, नो डिस्क्लोजर्स, हाउएवर जनरलाइजेशन अगेन आर फॉल्स. तो इसमें भी आपको शायद यही प्रेडिक्शन मॉडल चाहिए हो आखिर में ना. So the path is as important as the destiny, and the path of this presentation I would be like introduction to peripheral arterial disease followed by some indications, advances and controversies, and in few cases. So since we are more interested in cases, ये थोड़ा सा peripheral arterial disease का वो है introduction है. Sir ये numbers हैं for this is some data, recently published data and all that is available, that most of these patients that have coronary artery disease, more than 60% of these patients also have peripheral arterial disease. One in 5 of them may all die just because of the cardiovascular mortality associated with, and also may get unnoticed. A patient who is having, so this is the relevance here, sir. So you, I'm sorry with but ये कोलोरेक्टल कैंसर और इससे जो है थोड़ी सी नीचे है पेरिफेरल आर्टेरियल डिजीज की मोर्बिडिटी. तो दिस इज इंटरनेशनली पब्लिश्ड डेटा एंड सो वी कैन नॉट वी आर जस्ट मेकिंग अ पॉइंट हियर दैट इट इज समथिंग coming from mashallah such an expert. It is a point that needs to be mentioned that this is something that is being under diagnosed, under addressed, and of course then under treated. So this is something why we need to discuss it, and severely symptomatic patients have definitely decreased expected survival of them. So the treatment aims again so to decrease the cardiovascular morbidity and improve the wound healing and avoiding the major amputation. Options again can be best medical therapy. Revascularization, open endovascular, and again amputation is also a valid option for a lot of these patients. सो एंडोवैस्कुलर वर्सेस ओपन रिवैस्कुलराइजेशन में ओपन में कभी भी आप इसको कभी भी ये कहना कि जी कार्डियक सर्जन जो है वो बेरोजगार हो जाएगा, वैस्कुलर सर्जन जो एंडोवैस्कुलर नहीं जानता होगा ये हो जाएगा, ये एक बड़ी मुश्किल सी बात है. देयर ऑलवेज विल बी रूम फॉर बाईपासेस एंड यू कैन नॉट ऑल यू नो स्ट्रिक्टली कभी भी आप ये कंपेयर नहीं कर सकते. अभी भी गोल्ड स्टैंडर्ड्स जिनके अगेंस्ट ये चीज़ें कंपेयर की जाती हैं वो ओपन बाईपासेस हैं. दे हैव गॉट a lot of advantages. और हमें ये भी बहुत जहन में रखनी होगी कि while considering मैं यहाँ पे एडवोकेसी एंडोवैस्कुलर की करने आया हूँ, लेकिन the point is कि we have to individualize things. We have to see what we are doing, what are our resources, हमारे पास कौन सी चीज़ लास्ट करेगी, हमारी पॉपुलेशन कैसी है. So open surgeries, doing a good open bypass, we have cardiothoracic surgeons as well as here, so they can also have a word of it kg stenting versus an open bypass. So longevity and higher patency rates are associated with and has been a gold standard for years now. So as far as the endovascular treatment is concerned, so you all have no wounds and wound related complication. However, the anesthesia is much more less. The cost again then comes to be an issue. So evolution इसकी dates back to 1924 जब ये सोडियम आयोडाइड का इंजेक्शन, इंट्राआर्टेरियल इंजेक्शन की डिस्कवरी हुई. फिर then it came a long way. Then the Seldinger technique was introduced, followed by transluminal treatment of arteriosclerotic obstruction by Judkins. So we've come a long way since then. Palma's stent की placement was again a revolutionary thing. जिसके बाद EVA placement and उसके बाद boom of endovascular devices आया, जिसमें बहुत सारी चीज़ें have revolutionized what we are doing, how we are managing the patients with peripheral arterial disease and treat other vascular problems by means of endovascular approaches. सो अब प्रॉब्लम ये आ जाता है कि आपका पेशेंट है क्या ना. बेसिकली अगर हम क्लासिफाई करते हैं तो देयर इज अ पेशेंट हु इज एन एसिम्प्टोमेटिक पेरिफेरल आर्टेरियल डिजीज एंड क्लॉडिकेंट वर्सेस अ पेशेंट जिसको क्रॉनिक लिम्फ थ्रेटनिंग इस्कीमिया है, जिसको हम प्रीवियसली CLI की टर्मिनोलॉजी यूज करके इसमें रेस्ट पेन और जिस पेशेंट को गैंग्रीन है उसके साथ. तो पेशेंट हु हैज गॉट एसिम्प्टोमेटिक पेरिफेरल आर्टेरियल डिजीज एंड क्लॉडिकेशन, revascular procedures are not indicated in asymptomatic peripheral arterial disease, and this has been supported again by multiple evidence. However, the exceptions are, to interventions that are aimed to enhance the long-term patency, and a patient who has gone clinically asymptomatic but already has gone a first revascularization. तो आप हर पेशेंट को एंडोवैस्कुलर इसलिए ऑफर नहीं करते कि जो है you can do it. Yes, he needs it. That is the main indication, of course. And for a claudication, it is said that you have to, sometimes it's said that make claudicants beg for intervention. So the long-term survival and fate of the leg in de novo intermittent claudication, this is again a landmark paper published जिसमें इन्होंने claudication में intervention की बात की. तो हमने फिर देखा कि the main points are कि the interventions here again are the same outcome in intermittent claudication के जो patients हैं उनमें endovascular treatment का we did not have any significant advantage, as well as the fact that these patients, a lot of them don't even progress to critical limb threatening ischemia. However, जो कि patient आपके पास presently critical limb ischemia के साथ कर रहा है, that is associated with a significant risk of cardiovascular morbidity as well as having a major risk of having a major amputation. So these are the primary patients जिस पे खास तौर पे probably हमारे setups में we have to focus on. So again, the advances are too many. Now बहुत सारी advances, pedal interventions इतनी हो रही हैं कि you are not even aware of the names of the technologies. जैसे AI based imaging है ना, perfusion scanning जितनी होती हैं कि you don't have to get familiar with all of them. The point is कि क्या being medical student हम लोग एक अच्छी history examination ले सकते हैं, एक अच्छी हम ये exclude कर सकते हैं कि वाकई this patient की पल्स ही देखने आ रही है या नहीं. हमारे पास being a vascular surgeon, what we come across a sad finding is that even being in Karachi, जहाँ पे आपके पास सारी facilities available होती हैं, तो आपके पास patient इतना delay referral होता है कि जब तक उसकी उंगली काली नहीं होती ना, this is not referred to you, or this is not something that is done by simple physicians, or specialized centers are doing this. So this is something probably that we need to focus on in the beginning. So again, risk of reintervention is these patients is pretty high. Out of 367 patients, you had 467 reintervention हुई है. एक large data की मैं आपसे ये data share कर रहा हूँ जिसमें 367 patients में 497 reinterventions हुई. तो बहरहाल this might be possible in some scenarios. However, we have to look into it कि जी claudicants में when do we have to intervene. So this is the trade-off. I get to stand a claudicant, and you may have to come back after 6 months and get a fasciotomy done. So this is the recommendation that I also already done with, an indication for intervention in claudication would be let the claudicators beg for intervention. So there is either it be lifestyle limiting claudication or failure of medical therapy. So इसमें aortoiliac disease, the larger the vessel, the concept is pretty similar. The larger is the vessel, the better the results of its endovascular treatment. So for aortoiliac disease in a patient with a life-limiting claudication and stenosis, balloon angioplasty plus minus selective stenting can be done, and in a CTO you do a primary stenting. However, in FEMPOP disease, अभी भी जो recent study है, and they suggested कि जी there are big trials going on कि जी DCBs का बड़ा role है. So these are costly treatments. However, they have found out कि जी DCB primarily does not make much difference as compared to the results of doing an angioplasty alone. So what about CLTI? Now this is the real problem here, and the cost goes very high. अगर आप पेशेंट लेट देखते हैं, लेट भेजते हैं, तो all of these interventions end up having more cost, and the outcome again are not so much good. So angioplasty versus stenting और प्राइमरी स्टेंटिंग फॉर बोथ स्टेनोसिस एंड सीटीओज. अब आप इसमें बात कर सकते हैं कि बैलून माउंटेड स्टेंट यूज करना है, सेल्फ एक्सपेंडेबल स्टेंट यूज करना है. सो दैट डिपेंड्स ऑन द साइट मेनली. जहाँ पे ऑस्टियल डिजीज है, जहाँ पे यू नीड मोर रिकॉइल, मोर स्ट्रेंथ एंड टू प्रिवेंट रिकॉइल, so you use a precise deployment. तो इन सब जगहों पे you use a balloon mounted stand, and otherwise you use a self expandable stand. So BMS versus covered stand is a debate that is still among the controversies that need to be solved out. For infrainguinal disease हमें बस BASI-LI और Basel 2 का डेटा मौजूद है, and they still say that the results of surgery again are not at all inferior to doing an endovascular therapy for these diseases. So coming on to the recent advances, you can have a lot of CTO interventions. There are drug concept balloons, concept of vessel preparation, atherectomy devices, and having CTO crossing devices. So again, all of these options are available. However, you need to have proper training, you need to have exposure to these devices, you need to have cost issues addressed, and all of these need to be taken into account, and also the patient selection is to be very important. So a few case discussions that we have. So number one is a 67-year-old gentleman who was an ex-smoker and diabetic with a good functional class. He had left big toe gangrene. His right-sided femoral and popliteal pulses were palpable, and with no left-sided, they did not have any pulses. On echo, there was EF of good 50 to 55%. On CT angiogram, we had calcified atherosclerotic aorta with occluded left iliac, about a centimeter from the origin, and distal deformation of the common iliac artery via the collaterals, diffusely atherosclerotic SFA with occlusion as well, and again popliteal artery faintly opacified. Total arteries cannot be identified clearly because of the large calcium burden, as well as proximal flow occlusion. तो अब इसकी ट्रेडिशनल अप्रोच ना इसकी ये होती कि probably somewhere like a reliable option might have been doing an aortic bypass and going with a fem-distal bypass, either a staged procedure or a combined procedure. This would have required a very large incision or a longer stay in the ICU, and again probably a lot of wound complication if the wound does not heal well. So alhamdulillah, we managed this case by endovascular means. We looked at the CT scan and thought that this was the this is the angiogram, initial angiogram that we did. अगर आप इसको गौर से देखें ना, इस एंजियोग्राम को यहाँ पे, तो ये एक बहुत छोटी सी लाइन नजर आ रही है. So this is very little, this very little passage was our the way through which we passed into the distal vessel, and alhamdulillah we are fairly successful using an O35 glide wire. Alhamdulillah we were able to negotiate this lesion and pass distally. This was the initial angiogram, also showing the disease. This is from the top, but before crossing the lesion. And this was showing a diffusely atherosclerotic SFA. Now that also terminates into this occlusion someplace here, and only to reform via the popliteals. This is the popliteal, and the image again of the tibial vessels could not be obtained. Number one, because of the calcification. Number two, it was the flow. We could not get the flow in because we were proximal to the occluded segment. So what we did was, alhamdulillah, we managed to pass the wire distally. We first ballooned it with a 4 mm balloon, then upsized it with a 7 mm balloon, and then the plasty of the SFA crossed the lesion, and then also did distal plasty as well. So this was our result. We still had some residual stenosis at the segment of common iliac. So we decided to put in a stent. So we alhamdulillah extended it. We used a Visipro balloon mounted uncovered stent. Alhamdulillah we had fairly good result of this after that, and these are the images that showed good opacification of the SFA, the common femorals, the SFA, and then going down again to the tibials. We did an angioplasty of the ATA as well, the origin of the PTA as well. So all of this was done with this much of an incision, alhamdulillah. So this I guess was not possible, all because अगर हम इसको ओपन करते तो probably this would have been a very major undertaking, but alhamdulillah we managed to do this case by means of endovascular, and it was fairly nice results alhamdulillah. So similarly images with PTA. अच्छा, इसमें एक चीज़ इंपॉर्टेंट ये है कि आपके मतलब एक तो फॉर some of these that are into this training, you have to look at these angiograms very carefully while doing the angiography, because diagnostic angiography is very important. This was the very little streak that was going in. If you had missed it or ignored it, you would not have, you had have thought कि जी ये CTO है और आप उसको क्रॉस करते with a hoop, with a loop के साथ ना, और फिर that might have not been able to cross that lesion. Secondly, अगर आप ये देखें लीजन, ये एक बहुत distal lesion है. This is a lesion in the PTA. Apparently this is a very easy to cross lesion, a small segment lesion, but this is such a distal lesion and with so severe calcification. अच्छा, मसला है कि severely calcified का ना हमारे पास जो हमारी इन्वेंट्री ना होती बहुत लिमिटेड है. उसके लिए दुनिया में they first if there's a they are treating an SFA lesion, they put in a filter wire first, do an atherectomy, then debulk it, then stent it, and that is how that is done. We already only have these some CTO wires that we can manage it. So at times you have to be very careful of managing these choices. Being a vascular surgeon, you know कि जी this is something that you can use as a bypass target. So you cannot destroy that. While those people that are not familiar with this may try every attempt to open this by endovascular means. That is not the case. Being a vascular surgeon, you are aware of the bailout options and you cannot destroy a bypass target. So being aware of the fact, we tried it, and alhamdulillah we managed to cross this very small lesion here at the base with a calcified vessel just by some negotiation. When you go on through these various lecture series and see the imaging, so imaging is so important. The point I want to make is that you want to see the imaging very close, and you have to have some good systems. Just say Dr. Asan ne kaha ke hybrid suit maybe at times, or a good imaging modality. CM के images और एनजियो के इमेजेस में बहुत फर्क होता है. मतलब ठीक है हम कर रहे हैं सियाम से और इट्स अ गुड स्टार्ट. However, the imaging is so different कि आपके पास अगर एक अच्छा रोड मैप मिल जाए ना तो जस्ट आप उसके थ्रू ही बहुत सारी चीज़ें कर सकते हैं. आप कंट्रास्ट की डोज बहुत कम कर सकते हैं. आपकी बहुत सारी कैल्सिफिकेशन कैन जस्ट भी में आपका इमेज गाइड होती है कि आप उसके थ्रू ही क्रॉस कर लेते हैं लीजन्स को. एंड सो अ गुड सिस्टम इज इम्पॉर्टेंट एंड इट्स ऑफ कोर्स इज लाइफ एंड लिम्ब सेविंग. Similar some of the SFA angioplasty. ये ना SFA, this point I want to make, ये SFA की जो angioplasties है ना, these are इनको देख के एंजियोप्लास्टी की जगह लगने में ना these look very very simple to do because this is a small relatively larger size artery. आपको लगता है आराम से क्रॉस कर लेंगे. थोड़ी देर बाद हमने रन लिया, हमने देखा यार फ्लो ना जा रहा है लेकिन थोड़ा हल्का जा रहा है. तो वो हल्का आगे इसलिए जा रहा है कि उन्हें एम्बुलाइज कर गई वैसे. तो these are notorious for embolization, and once you have the experience and some bailout available, और खासतौर पर अगर आपका रन ऑफ सिंगल वेसल का रन ऑफ है ना, तो और अगर आपने वो खराब कर दिया ना तो आपका बाईपास भी जो है ना वो फिर आप ना मतलब एक इमरजेंसी में आपको बाईपास करना पड़ जाता है, जो आप डू नो हार्म वाली पॉलिसी को अपने. और इनिशियली जो है ना दिस इज अ केस आई एम शोइंग, बट मतलब आप ये करते हुए बहुत दफ़ा सोचते हैं. So this is some of these cases, the urinoplasty, some of the TBL cases. All of these are alhamdulillah but doing and trying to do things. Kuch EVARs we did at our place in early setup. एक सर्विस को स्टार्ट करने के लिए a few points that I just want to briefly mention कि जी starting a service at a new place or at a place that is relatively old, we come across some challenges. This was something that I presented in WestCon. Say if it was easy, everyone would have done it again. So the challenge number one is not anything else but having a free mind. So the mind control is something that we have been worked on a lot of things. So we need to have a free mind, and we know when we can do it. Yes, so we can, inshallah. So again, training is also a very important aspect. The training of the trainers needs to be the first point that taste has to be taken into account. Those that are training people like myself are to be familiarized with so many advances that are coming up, and need to be abreast with some of these methodologies so that we can train our trainees well. Again, the trainees and pathway, these are some of the challenges that we will be facing. Funding and resources again also and always has been a problem. One issue is tough for ये कंट्रोवर्शियल इशू है जिसमें हमने बड़ी बात की, थोड़ा सा हमारा टॉपिक साइड जाएगा, इसको ऐसे ही रहने देते हैं कंट्रोवर्शियली, सो वी कैन ऑल हैव आवर ओन say on that. So, disease burden and lack of awareness, sir, again is a big number. Diabetes में पाकिस्तान का पहला नंबर है, डायबिटिक का 1/3 डायबिटिक जो है ना पेरिफेरल आर्टरी डिजीज के साथ है, तो you can think of how what the number is. We're just seeing the tip of the iceberg. Again, lack of awareness of disease and seeing these patients late increases our workload way forward. We a lot more than we need to handle. So the way forward again is freeing the mind, saying yes, you can do it, inshallah, and you have to just stay focused, take your time, inshallah, and you will be there. So alhamdulillah, just a small example, by 2019 to 2024, a few number of cases that we have done, alhamdulillah, and inshallah we're trying to improve on this. So this is our ranger suit. Also, got arranged from donation. This is, I believe, also the trust and based hospital, and we can also. Sabi has told me that he also has an access to the cath lab, or alhamdulillah, we can have some dedicated facilities that can really, uplift the system. So our team, I always and also and always will be saying that the Banasi main center, we can see our professor Dr. Ziyad Sufi, who has been a teacher for all Dr. Ziyad and Nera. अपने teachers and अपने mentors का आप कभी भी you can never be thankful enough for them, because these are and of course your students, because of these are the real reason they are here for as well. So the future vision is a national vascular registry, some aortic venous and malformation fellowships, and enhanced national and international collaboration. And the next, this is something of the next. जिसमें हमने कहा था कि नेशनल एंडोवास्कुलर सिमुलेशन बेस्ड ट्रेनिंग हमने शुरू करनी है इंशाल्लाह. सो मे बी वी कैन हैव द वेस्प इन द नेस्ट. क्यों डॉक्टर सना? We can have the wasp in the nest, yeah. So we can collaborate and integrate the things, so it can be a wasp's nest as well. So inshallah we have a bright future, and thank you so much for the vision. Sir, questions please. Sir,
any questions regarding this presentation?
चाय कब मिलेगी? चाय कब मिलेगी? The first question. Sir, thank you so much. Sir. जी सर.
Number of cases coming to the vascular surgery unit are different from type of cases coming to the general surgery unit. Our observation, again, we are deficient in data, but our general observation, and to some extent the work which the residents have been doing, most of them predominantly are non-salvageable ends, because they first they are being treated by GPs or non-GP quacks. Then when they come to medical units, again, somehow they get delayed there prior to referral to surgery. And once they come to surgical units, those cases are predominantly not salvageable.
So,
plastic surgeons are also not very comfortable rotating back because of the vascular
true.
Problems there. So, what's your observation on this?
सर अल्हम्दुलिल्लाह मैं ये कहूँगा कि ओवर द लास्ट 5 ईयर्स ना अल्हम्दुलिल्लाह चीज़ें कुछ ना कुछ ज़रूर बेहतर होना चाहिए. अब लोगों को ये पता है, लोग ये तो नहीं जानते मैं कौन हूँ, लेकिन ये जानते हैं अल्हम्दुलिल्लाह कि हमारा एक यूनिट है जिसका नाम ट्रॉमा सेंटर है वैस्कुलर सर्जरी का. अगर कुछ ना कुछ अगर इनको वैस्कुलर का मसला है ना, कुछ जगहों से तो बड़ी जल्दी रेफरल होने लगे हैं. अच्छा, 2-3 तरह के मरीज आते हैं. एक तो पेरिफेरल आर्टरी डिजीज़ के बड़े मरीज आते हैं, दूसरे जो है ना वो ट्रॉमा के बड़े पेशेंट्स आते हैं. ट्रॉमा में जो अगर हम पेरिफेरल आर्टरी डिजीज़ की बात करते हैं ना सर, तो पेरिफेरल आर्टरी डिजीज़ में पहले तो ये ऐसी था, बिल्कुल ऐसी कि अभी भी मतलब आप कह सकते हैं 1/3 ऑफ द सिनेरियोज लाइक दिस कि यू गेट टू एम्प्यूटेट दोज लेग्स दैट, मतलब आप बिल्कुल ममीफाइड लेग्स लेकर या बिल्कुल वेट गैंग्रीन के साथ आते हैं. लेकिन अदरवाइज नाउ थिंग्स आर गेटिंग बेटर इवन फ्रॉम पेशेंट, इवन फ्रॉम सेंटर्स, जो कि क्योंकि ज़्यादातर ना पेशेंट्स इंडियन सिंह से बहुत आते हैं, तो वो भी अब अगर उन्हें थोड़ा सा डाउट होता है ना, या ऐसा होता है ना कि एक उंगली काली लगती है, तो पाँव काला नहीं लगना होता, पाँव काला होने से पहले भिजवा देते हैं. हाँ, उंगली पे कर लेते हैं तजुर्बे, एक आध काट दी, एक फिर दूसरी नहीं हुई तो फिर लेकिन फर्क है. देखिए मतलब ऐसा नहीं है कि आई वुड से कि नहीं कुछ नहीं, ओवर दिस इयर्स स्टिल हैविंग दिस. नो, सबसे बड़ी बात ये कि हमारे पास अल्हम्दुलिल्लाह 24/7 भी हो रहा था और फ्री ऑफ कॉस्ट हो रहा होता सारा. तो दे नो कि इट्स नॉट गोना चार्ज देम एनीथिंग. Plus now they have their name at stake as well. Amputating someone doesn't give you a good name at all, especially in private practice. So now I think we are seeing a much more earlier referral then we used to have him. Still problem exists, मतलब इस पे बहुत ज़्यादा काम करने की ज़रूरत है कि आप physician awareness पे काम करें, and then patient awareness, that is a bigger group, so physician awareness can help again. Yeah.
We should
Focus on.
more on disease prevention and advocacy.
Nice.
What about the disease behavior? Because if we compare it, the data which usually we get from
West.
the Western world, and we quote that data, we really don't have our own data.
नहीं.
But what we see in surgical oncology is
Sir.
the disease behavior is quite different here.
True, sir.
For example, if we talk about colorectal malignancies, we see colorectal malignancies with loco-regional advanced disease, not metastatic disease. In the Western world, it is the other way around. You see it small tumors with multiple liver metastasis or peritoneal metastasis. But in Pakistan, we see larger diseases, big size tumor with very few presenting with colorectal, with liver metastasis.
Sir.
So what about, I was,
Yeah.
one of my friends who's a vascular surgeon, who's a cardiothoracic surgeon and does more in vascular surgery. He says he has experience in working abroad, and the vessel size were,
Larger.
Western population, the vessel size that is relatively larger if you compare with the vessel size here in our part of the world. So when we talk about peripheral arterial disease, how do you compare that?
सर बाहर का तो डॉक्टर इलियास सादिक बैठे हैं, डॉक्टर एस भट्टी बैठे हैं, वो बता देंगे, मैं बाहर कभी काम नहीं किया। हाँ, मेरे हिसाब से दो डिफरेंसेस हैं सर। एक तो अर्लियर एज ऑफ प्रेजेंटेशन आई बिलीव, एंड दूसरी जो एज कंपेयर टू स्ट्रिक्टली एथेरोस्क्लेरोटिक डिजीज ना, पेशेंट्स हैविंग थ्रोम्बोटिक डिजीज are I see them a lot, मतलब ऐसे पेशेंट्स और they don't respond that well as purely atherosclerotic disease जिसमें आपकी endovascular works like anything. So a lot of these patients, क्योंकि आपने वेसल की आपने क्लॉट में करके आ गए ना, अभी अपने प्लास्टिक की थोड़ी देर बाद आप जाएंगे एंजियो लेंगे, बंद हो जाएगी. So a lot of these patients, especially the younger groups, are associated with this. This is my observation, sir. Sir को mic दीजिए. Mic.
I think you're right. Number one, there are basically, I think, two differences, major differences. Number one, we see a lot of disease which is distal disease, below knee vessels. Now, in the UK, we used to do a lot of femoral-popliteal bypasses, but I think that in the rate that we actually can't do much of femoral-popliteal bypasses because of popliteal artery disease. So we end up doing actually distal bypasses of femoral artery to either posterior tibial artery, peroneal or AT, or even pedal bypasses, and doing a femoral to the pedal artery, which is right in the foot. So this is one difference. We have a lot of diabetes, so we get a lot of patients with below knee disease as well. Many of these patients, as you said, that they have got unsalvageable limbs and they end up in actually major amputations. So this is one person, and then yes, you're right. So we have smaller vessels, and this is the reason that we have relatively higher rate of aortoiectasis. We have higher rate of aortic occlusions in our population. And as Fahad said, that we see a lot of young patients with very aggressive peripheral. And these are the patients who also have surprisingly and very advanced coronary artery disease. So they have a very high incidence of mortality while they are admitted in the vascular ward. So sometimes it is not uncommon that we see a patient who is waiting for surgery or waiting for investigation in a vascular surgery ward. He suddenly gets a massive MI or he gets a stroke. So these are the patients who are at very high risk for developing many vascular problems. So this is just a comment, but I would like to actually comment and appreciate the efforts of Fahad, because I know Fahad since a long time, and I was serving in Quetta, and many of the patients which I couldn't do there, they actually used to go from Quetta to Fahad for various endovascular interventions. Now, Fahad is remarkable, and you would, Karachi is such a big city. There are so many trauma patients there. There are so many vascular injuries. Now, actually, these vascular injury actually nearly all of them go to trauma center, and the other hospitals are not having any vascular trauma patients. So you can imagine his workload in terms of managing the trauma patient. When you ring him up, maybe in at 8 o'clock or 10 o'clock at night, he would be in operating theater and doing some vascular traumas. And he has trained many vascular surgeons, and they are working with him. He has, I think, made a lot of effort in establishing the trauma center, a very good vascular unit. And our impression maybe of Sindh government maybe that they're not doing a lot and they're not spending a lot on the people. But I can tell you, I think Sindh government knows that Fahad is doing a very good job. So they have given him a lot of funding. They have provided him a hybrid theater. They have provided him a cath lab, and they've also given him a lot of inventory as well. So he is doing a remarkable job, and I think this unit is one of the very busy unit and maybe one of the very large vascular unit in the whole world as well.
Thank you, sir. Thank you. Thank you, sir. Dr. Ilyas.
Thank you very much, Fahad, for a wonderful presentation.
Thank you, sir.
You're doing a wonderful job in Karachi. A few minutes about things and certain questions. Now, there are significant differences between the blood vessels of Western population and Asian population, and the main difference is the size. We have a smaller size coronaries and we have smaller size peripheral vascular disease. Some people think that it's because of the overuse of wheat we use in our diet, but obviously nobody knows that it could be genetic or something. Now, your other question was another difference. Main difference is the thrombosis. We see too much thrombosis in normal vessels in Pakistan, and even disease vessels and the normal vessels. That kind of thrombosis we never saw in Western population. So we have to deal with the double pathology, stenotic or occlusive pathology, along with the thrombosis. And secondly, regarding your comment regarding the incidence, obviously, that answered well. Incidence is very high, and we are not quoting the Western numbers. We have seen our own eyes in the last 12, I'm here for the last 12 years, and the number of and the incidence and prevalence of peripheral vascular disease is extremely high. It's much more than we thought before coming here. And another important point I want to raise here, and rather a request, a message for our general surgical colleagues, not to amputate the dry gangrenes, please. So most of the time we see patients with an amputated toe or amputated partial foot or amputated limb, and the toe was only a dry gangrene. Without investigating, without getting the doctor scan, without getting the CT angio, without referring to the vascular surgeon. So people come with an amputated toes. So I think it's a very, very serious, it has very serious implication for the further management of the patient. So this message should go across to all the general surgical community that please do not amputate the dry gangrenes.
Thank you, sir. Thank you.
So this was the end of our presentation. Before the conclusion of the session, I would like to slide the sheet for distribution of the sheets and certificates. If you can join us.
अच्छा सर लेक्चर हॉल 1 में
First, our speaker.